Good morning, everyone. My name is Vascular. I'm one of the intensivists here in the CV ICU at HMH. I actually work with these two stellar nurses. So I'm going to build my presentation basically on what I presented to you earlier. So when we talk about shock, the first thing that we need to understand, what is shock? When I ask these questions, I get answers like hypotension, elevated lactate, tissue hypoperfusion, and answers like that. And that's all part of the spectrum. But the main physiology that happens in shock is, I guess the slide is going to come right. Okay, so shock is basically tissue hypoxia. And that happens when either you don't deliver enough oxygen for the rest of the body, or the body demand has increased, or the body is not able to use that oxygen that you are delivering. So this is when the body switches from the aerobic metabolism into anaerobic, and the lactate will start going up, and you're going to start having multi-organ dysfunction. So in a sense, it's a reduced tissue perfusion, and that most of the time correlate with hypotension. So these patients will be hypotensive. But the main point is that patient in shock can be also normotensive or even hypertensive. And we're going to see why later on. I don't know why the slide come weird that way. Okay. So back to physiology. As we all know, that fluid moves from the higher pressure to the lower pressure. And that the way the flow goes. So if we apply the formula, so the flow from the higher pressure to the lower pressure equal the flow times the resistance of the circuit or the tubing where the flow is going through. So if we apply the same concept on the human being and the human circulation, then that formula is going to be, the higher pressure is going to be the MAP, which is your arterial pressure, minus your lower pressure, which is your CVP or right atrial pressure. And your flow is going to be the cardiac output. And the resistance is going to be your systemic vascular resistance. It's the resistance of the vessels, of the arteries, and the veins that the blood is going to go through. So if you have someone who's hypotensive, then you have to ask yourself the question, is my problem, is a flow problem? Is it a cardiac output problem? Or is it a resistance problem? So if you have someone with high flow stage, just like what we have in septic shock, the cardiac output is high. The problem is the low SVR. So in this situation, the treatment would be to start an agent that restore back that SVR and get the blood pressure back up. But if you have someone with a low flow state, like a cardiogenic shock, when there is not enough cardiac output, then adding an agent to increase the SVR like a pressor is not going to solve the problem. So we have to do something to increase the cardiac output, and we're going to see how. All right, so we'll go back to the oxygen delivery. This is the formula for oxygen delivery in the human body. So the oxygen delivery equals the cardiac output and the oxygen content in the arterial blood. So the oxygen content in the arterial blood depends on your hemoglobin, because you need the red blood cells to carry the oxygen, and the saturation of the arterial blood. So if you have someone with an acceptable hemoglobin and you have O2 sat that is in upper 90s, then you optimize the oxygen content of the arterial blood. So your oxygen delivery will depend entirely on your cardiac output. And we know that cardiac output equals the stroke volume and the heart rate. So if you have a normal heart rate, then if you have the cardiac output will correlate with the stroke volume. And what makes your stroke volume lower is either the preload, so you don't have enough fluid inside the body or inside the heart, or is it a cardiac function where the heart is not able to pump efficiently, or is it an afterload problem when you have so much resistance to the heart, so the heart is not able to push the blood forward. So our body is designed in a way that addressed our oxygen delivery is 5 times the amount that we need. So at any given time when you're at rest, if you have a normal heart and normal oxygen content in your blood, your heart is delivering 5 times the amount of oxygen that your body needs. So that means the body is only utilizing 20% of the oxygen that you're sending to your organs. The reason it's designed this way is just to give us enough reserve in case we need higher oxygen consumption later on. But when the oxygen delivery starts dropping, then the body is going to start utilizing more and more of that cardiac output or oxygen delivery that you're sending. So you're going to drop from 4-to-1 to 3-to-1, and then eventually you're going to reach 2-to-1. And when you reach 2-to-1, it means that the body is utilizing more than 50% of the oxygen that you're delivering. This is the danger zone. This is where you don't have any reserve. That means below this point, if your body for any reason requires more oxygen, the body doesn't have enough. And this is when we start seeing, increase in the lactate. This is when we start seeing the organ dysfunction. So whenever you reach that point, this is the danger zone. You have to do something to restore your oxygen delivery above that point. So to talk on cardiogenic shock in particular, this is the classical definition of cardiogenic shock. So basically you have someone with impaired cardiac dysfunction, with a systolic blood pressure less than 90, or a MAP 30 points below their baseline. If you have any kind of hemodynamic monitoring and you were able to get the cardiac index, these are the patients who have a cardiac index less than 1.8 if you are without support, or less than 2.2 when they are on support. Now, as you can see here, it's a general definition. A lot of patients might go undetected if you use that definition, unless you have cardiac monitoring or unless they are truly hypotensive, you're not going to be able to identify them. And then it doesn't put these patients on which stage they are in. It doesn't tell us how sick they are. Because you have a cardiogenic shock patient who might be on one of the butamine and he's doing okay, but you might have someone who's on multiple pressors, multiple inotropes, who's on a device. And they all go under the same definition. So that's why the SCAI Society came up with the classification for cardiogenic shock. So basically you have 5 stages. The first stage, which is at risk, which can be anybody. And then you have the B stage, which is the beginning of a cardiogenic shock. Then C, which is the classic, where the previous definition apply. And then D is deteriorating, and then E is extremis. And we're going to go over these quickly. So I'm not going to go over this. I think Hannah and Jenna already did. So to go into specifics about these stages, so stage A are patients who are at risk. These are normal patients, Everybody can be at risk, everybody can get an MI, everybody can have an issue that reduce their cardiac function, so I'm not going to go over that. But then we'll go to B, which is the beginning. These are the patient who doesn't have hypoperfusion yet. These are the heart failure patient probably that you're going to see on the floor. These are the patients who have elevated GVPs. They are the ones who have crackles in their lungs when you examine them. They still have a normal lactate. They have elevated proBNP. And they might be hypotensive or borderline blood pressure, but their perfusion is still intact. So their lactate is normal. Their exam is relatively normal. They are warm to touch. They have good pulses. Now we'll go to C, but this is the classic. This is when we start seeing evidence of hypoperfusion. So here the lactate will start rising, the creatinine will start going up, urine output is going to start dropping. These patients often you're going to see them on BiPAP, or they're going to come to you either intubated or non-invasive because they have significant pulmonary edema. They are not able to maintain well. They are not perfusing their brain very well, so they're going to be altered or sleepy. And if you put a SWAN in them, then these are the patients that are classically going to have the low cardiac index below 2.2. They have a high wedge pressure. The PAPI is going to be low. And their CVP to wedge pressure ratio is going to be more than 0.8. Now, moving on to D, which is deteriorating. So these are the same patients who are in C, but probably you start them on pressors or you put them on inotrope, but they're still deteriorating on you. Their lactate is still rising. The multi-organ dysfunction hasn't improved. Their lactate is keep rising. So these are the patients who are probably going to go on a device soon. And if you don't do anything in D or you don't do anything adequate in D, then you're going to reach E, which is the externus. And these are the patients who are pericoding. They are very acidotic, their lactate is very high. Probably they are on CRRT at this point, but it's not working. These are the patients that you're going to be calling your ECMO team to come and put them in ECMO because they're going to code on you at any time, or they're probably already coded and you did CPR on them. So we're going to talk about the management. I just want to give a reminder for all of you, probably you know about this. These are the main receptors that we're going to manipulate in cardiogenic shock in order to improve the contractility and improve the blood pressure. So alpha receptors, we know it's in the vascular bed, and it's going to give you vasoconstriction when you stimulate alpha. Beta 1 is predominantly in the heart, and when you stimulate beta 1, you're going to have increased heart rate and contractility. Beta 2 is mostly in the vascular bed, and when you stimulate beta 2, you're going to get vasodilation. And then the dopaminergic receptors, it's throughout the body, and depending on the dopamine dose, you're going to stimulate one receptor versus the other, and you're going to have a variable physiologic effect. So the first agent that we all use in any cardiogenic shock, it's the cornerstone, is the butamine. So the butamine works on the beta receptors, and it works more in beta than beta 2. The ratio is 3:1. So what you're going to get from the butamine is increasing in the heart rate and increasing the contractility. But then at the same time, you're going to get a little bit of vasodilation also too, because it stimulates the beta 2 in the vascular bed. Now the main point here, when you put someone on the butamine, as we talked earlier, blood pressure equals the cardiac output and the SVR. So if your butamine boosts your cardiac output up, but in the same time decrease your SVR a little bit lower, your net effect that the blood pressure is going to improve. But if you have someone who has end-stage heart disease, someone who's already on the butamine probably at home coming to you, he has very few myocytes left. You put them on the butamine, you might not get anything from stimulating for beta 1. The cardiac output is not going to improve. Or you're going to get that the beta 2 effect, and they're going to go vasodilated, and the blood pressure actually might drop. So keep in mind when you put someone on the butamine that most of the time in cardiogenic shock, the blood pressure is going to improve, but there is always a possibility that might go hypotensive on you, so be prepared for that. The other inotrope or inodilator that we use is milrinone. Milrinone doesn't work through the beta receptors. It's actually worked through the phosphodiesterase pathway, so it increases the contractility and it doesn't have effect on the heart rate. So in theory, milrinone should cause less arrhythmia compared to the butamine. Milrinone is more potent vasodilator compared to the butamine, so when you put someone on milrinone, they're probably going to go hypotensive on you. Their SVR is going to drop in a good amount. So be prepared when you put someone on milrinone that is going to go hypotensive. So just to summarize about the inodilators, the butamine and the milrinone, since we are using them to boost the cardiac output, then we always have to titrate them against a marker of a cardiac output, not against a blood pressure. So don't titrate these agents based on the map. We already described that these agents might drop the map down, but that doesn't mean that they did not work. It doesn't mean that they did not improve the cardiac output. So if you have a SWAN, look at the cardiac output when you started the butamine. Did it improve? Did it not? Then I can go up on the dose. If you don't have a SWAN, if you have a central line, get an SVO2 before, and then check after starting the butamine and see if your SVO2 improved. If you don't have a central line, then you can do an echo, estimate the cardiac output from the echo before and after the butamine and see if there is any improvement. Use your clinical judgment if you are in a hospital where you cannot do any of these measurements. See if the urine output improve. Does the patient feel warmer? Is he maintaining better? But always use a marker of a cardiac output when you titrate these agents. Just a few pearls here. Milrinone is renally eliminated. Most of these patients have an AKI, so it can accumulate. So just be careful when you use it, especially if you have someone on dialysis. Dobutamine is easier to titrate. It has a shorter half-life. Dobutamine tends to wear its effect over time because of desensitization of the beta receptors. And as we said before, when you start these agents, just be prepared that they might go hypotensive. The other agent that we use in cardiogenic shock is epinephrine. It works great if you have a mixed shock, or if your patient is very hypotensive and you're worried if you start them on milrinone or dobutamine, their blood pressure is going to drop more. Epinephrine works on beta and beta 2 and alpha. It depends on the dose. You might get different effect. So usually epi doses below 10 microgram per minute tends to stimulate beta 1 mostly. It has neutral effect on the alpha receptors. So it can boost your heart rate, it can increase the contractility, and it's not going to get the hypotension that dobutamine and milrinone might induce. So a lot of times we might use it as a first-line agent or as a second inotrope. And you might see someone on epinephrine and norepinephrine at the same time because we're using the epinephrine as an inotrope. Just be mindful when you start someone on epinephrine that the lactate might start going up. So it's not unusual when you have someone with lactic acidosis, you put them on epi, that the lactate might go up. That's an expected effect from the epinephrine. Epi also can cause hypokalemia and hypoglycemia, just minor things. Norepi, this is the agent that we all have in any crash cart, in any hospital. I would say it's always your safe choice. If you have someone who's shocky, someone who's hypotensive, and you don't know what's going on, you are not going to go wrong with Norepi. You can put them on Norepi, get their blood pressure up, get them to an ICU, and then use either an echo or a SWAN or some kind of investigation to know what kind of shock you're dealing with, and then you can move from Norepi or add something else to it. So Norepi is always your first-line agent, any type of shock. It works by stimulating the alpha receptors, so it causes vasoconstriction. I'm going to go quickly. Vasopressin, it's also a vasoconstrictor also too. It works on the V1 and V2 receptors. It's usually an add-on agent. So in someone who is maxed out on Norepi or on high-dose Norepi, we add vasopressin. Sometimes we use it in combination with milrinone or dobutamine in order to counter that beta-2 effect. So it's always an add-on agent. Rarely we use it as a first-line agent or a sole agent. Issues with vasopressin, it has a long half-life, it's not easy to titrate, and it's a potent vasoconstrictor, so try to wean it off when you can. Phenylephrine, if you work on a cardiac unit, this is a no-no agent. No one uses phenylephrine unless you have an extreme indication for it. So if you don't have anything else to use, maybe consider it, but in cardiogenic shock patient, phenylephrine is not the right agent to use because it's only increased the SVR. So stay away from it unless you have a strong indication for it. Let's say someone who has an extreme tachycardia that you don't want to stimulate beta-1. You have someone with cirrhosis or something like that. So moving on, we're going to talk about the mechanical circulatory support. So now we are at a stage where we use the agents that we talked about already. Our patient is not improving. His lactate is still rising. His liver enzymes still going up. His respiratory status is getting worse. He feels more cold when you examine him. So this is when you're going to reach out to your cardiologist and say, we need to do something. We are going into stage D. So this is when you consider putting a device in order to augment the cardiac function, in order to improve the oxygen delivery and the perfusion. So the first mechanical circulatory support device we have is the balloon pump. It's the oldest we have. It's relatively cheap compared to the other devices that we have. It can be placed in the cath lab percutaneously, but also it can be done even at the bedside if you have a fluoro. You're going to need a sheath between 7 to 9 French. Most of the time it's going to go on the groin. Of course, when you put a balloon pump, if you're familiar with it, you have to look for ischemia in the limb where the balloon pump is going. You have also to check the position also too, as we're going to see later on. Do you need anticoagulation in the balloon pump? The answer is short term, if you're going 1-to-1, probably not. You can get away without it, but long term, probably you're going to use it. So these are how the balloon pumps are stationed. So the classic one is the one on the left, the A figure. So we're going to go from the femoral artery, and we're going to place the balloon above the renal artery branching and below the left subclavian. The other way that you can put the balloon, and this is when we do it in our cardiac ICU for patients we expect they're going to be on a balloon pump for a long time and want to mobilize them and get them out of the bed, is put it through the axillary artery. So you go from the axillary and you station the balloon in the same way, it just, upside down. Now, how does the balloon work? It augments the blood pressure during diastole. So basically, your balloon is going to sense when the diastole happens, either based on the decrotic notch on your arterial line or based on your EKG, and it's going to inflate during diastole. By inflating during diastole, it's going to increase the coronary perfusion, because we know that the heart gets perfused during diastole, and that will improve the myocardium performance. And at the same time, when it deflates during systole, it decreases the afterload on the heart, so it helps the heart pump more efficiently. So it's not a pump per se, it kind of helps the heart through these two effects. Now moving on, if we put the balloon pump in and the patient doesn't improve, or we think the balloon pump is not going to be enough based on the cardiac function estimation that we have, then this is when we reach out to our Impella. It's an axial flow device, so this is how it's usually stationed. Probably most of you have seen an Impella if you work in a cardiac ICU or in a place where they have an active cath lab. Basically, it's placed inside the left ventricle, so you have one end inside the ventricle that get the blood, and then you have the other end that's seen in the ascending aorta where it's going to put the blood back there. So it kind of offload the LV by helping it that way. How much flow you get from the Impella, it depends on the type of the Impella you're going to put in. If you have an Impella CP, you might get up to 3 liters. If you have an Impella 5.5, then you get up to 5.5 liters. Issues with the Impella, you need anticoagulation when you put an Impella in, so keep that in mind. Hemolysis might happen whenever we push the blood through a machine, then shattering of the RBCs can happen. And again, whenever we put a pump through a vascular structure, we always have to think about limb ischemia, and we have to monitor the perfusion in that limb where the device is going. These are the main types of the Impella that are available on the market right now. You have the Impella CP, which that we talked about. It gives you up to 3 liters. It can be placed percutaneously. This is the device that the cath lab is going to use. So if you have an Impella coming out of the cath lab, they're probably going to have a CP. An Impella CP is not intended to be used long term. So beyond 48 hours, if the patient still needs an Impella, you have to think about upgrading them to a different device because it can cause a lot of hemolysis. So it will buy you time until you think, is the patient going to recover so he doesn't need it, or do I have to upgrade to a different Impella device or a different machine? Impella 5.5 required a cut down. So here in HMH, we do it all in the OR. We put it on the right axillary artery. It's a bigger pump. It has less hemolysis effect compared to the Impella CP, but of course, it's also required anticoagulation. And then the last one we have is the Impella RP, which provides support to the right ventricle. So if you have someone with the right ventricular failure, then you put an Impella RP, basically it will drain the blood from the right atrium and return it back into the PA. So if you look at the Impella interface, that's how it's going to look like. It will give you right there at the bottom how many liters you're flowing based on the P that you choose up there. It will give you information about the positioning and also the motor function. And if you check an echo, just like we see up there, this is how we check for the Impella positioning. We kind of measure how deep it is inside the ventricle, and we adjust it based on that. This is an example on someone who had bipellas, so they have 2 Impellas. One Impella sitting in the left ventricle to support the left side of the heart, and an Impella RP to support the right side of the heart. I probably have seen a couple of patients like that here at HMH, but I mean, in theory, you can do it. Now, moving on to VA ECMO, Jenna and Hannah talked to you about VA ECMO. So what ECMO does is it kind of support both the heart and the lung because it bypasses both. So I provide respiratory support and hemodynamic support. It's the fastest to deploy if you have someone in an emergent situation. Someone is going to code on you at any time. He's not stable to go to the cath lab. You can unit them on the bedside. You put them on VA ECMO, you stabilize them. And then you move to something different in order to get them off VA ECMO. Same complications with ECMO that we with the other devices, limb ischemia, coagulopathy, bleeding, other mechanical circuit problems that we're going to get a clot or failure of the circuits. Probably they're going to go over that more in details in the ECMO workshop. This is an example of peripheral VA ECMO patient. So you have the drainage on the right side on the femoral vein, and you have the return in the left femoral or iliac artery. You can see that there is a branch there that goes from the arterial cannula to a small sheath that's sitting there in the leg. Because if it's a large cannula and it's sitting inside the iliac artery, it might impair the perfusion to the left leg. That's why we put this antegrade sheath in order to restore the perfusion to the leg so we don't end up with a limb ischemia. It's a standard practice here at HMH. Whenever we put a VA ECMO in, either our surgeon or our vascular surgery team come and place that catheter in. So if someone gets cannulated at your institution, you're not familiar with ECMO, always don't forget to remind your surgeon to put an antegrade sheath in. Because if you cause a limb ischemia and patient uses limb, it doesn't matter what we do next. Now, we can have different configuration with the ECMO. Jenna and Hannah probably are familiar with this. This is the Protic Duo. It's an ECMO catheter that is dual lumen. So single catheter with 2 lumens, basically it drains the heart, drains the blood from the SVC in the right atrium, and return it in the PA. So it provides support to the right side of the heart. So this is what we call a VPA ECMO. At the same time, if you have someone who has an oxygenation problem, you connect an oxygenator to it, and then it will oxygenate the blood for you. So it provides support to the right side of the heart and also provide respiratory support in someone who has respiratory failure. Tandem heart is not something that we do very often. Similar concept of ECMO. Basically, you put the drainage here in the cath lab using fluoroscopy. So you go through the femoral vein toward the right atrium. You cause a septostomy, and you place the tip of the catheter inside the left atrium. So you drain the left heart back to the pump, and then you push the blood back, just like an ECMO, into the femoral artery. Some centers, it's their preferred method of support. They are very familiar with it. Here at HMH, we use more VA ECMO. We rarely use a tandem heart, but it's something that can be done in the cath lab. So to summarize everything, if you have someone in cardiogenic shock, and he's not responding to the medical treatment, you have to ask yourself, is it time to put a device in? This is a multidisciplinary discussion, so you have to talk to your cardiologist, talk to your intensivist, check your resources, and then also you have to look at the patient factors. We're not going to put these devices in someone who's demented and is someone who's 95 years old. That's not reasonable. So you have to look, does this patient have an exit strategy? If I put them on a device, then what's going to happen next? The last thing you want is to put an ECMO in or put a device in, and the patient is sit there, they are not a candidate for a transplant or a VAD, and they have low chances for recovery. So have this discussion before you put the device in, and then if there is no contraindication, you have an exit strategy, then you have to identify, is it a biventricular failure, is it an isolated LV failure, or is it an RV failure? So based on these, you can consider which device you're going to use. Other thing to consider also, do you have a respiratory failure also too with the cardiogenic shock? And if that's the case, then you're probably going to need either VA ECMO or a Protec. If the lung doesn't need any support, then you can consider an Impella or Bipella, basically. This is a workflow recommended by Sky, how to titrate and how to escalate. So the idea is, when you check a lactate and the lactate is elevated, you do an intervention, always go back to the bedside and evaluate, did my intervention work? So this is why it's very important when you put the intervention in to check the lactate again. And if the lactate is not clearing or it's going up, this one we need to escalate. So you engage more people from your team. You consider probably adding a second inotrope or another medication to support the heart. If that doesn't work, then this is the time when we need to start talking about a device, or if the device is not appropriate, this one we should consider doing something like palliative care. So the idea is act quickly. If you don't act quickly and you let the rate rising, then you're going to have an adverse outcome, and this patient is not going to do well. So this is a slide, one of the studies. They look at the patient who survived mechanical circulatory support versus the patient who did not survive. So as you can see, the survivors are the ones who cleared their lactate by 24 hours after putting the device in. But also look at the baseline lactate when they put the device in, between the survivors and the non-survivors. So the non-survivors had a higher lactate when they put the device in compared to the survivors. And that tells you if you put the device early, before your lactate skyrocket, then you get a better outcome. So your first lactate is 3, now it's 5, then it's reaching 6. Act quickly. Put the patient on ECMO, put the patient on the device. If you do it when the lactate is 20, probably your patient is not going to survive. This device should look better. So the main message here of my talk is early recognition, see what stage your patient is in, move this patient if they are on the floor to the ICU. If you have a cardiac ICU, probably the cardiac ICU is preferably the right place for them. Apply the appropriate therapy, use your echo. We are here, we use the SWAN in our cardiac ICUs. It gives you very excellent information about how to guide your management. So SWAN guided therapy is very important if you can do it. And then as we discussed before, when the medication, the medical treatment is not working, start thinking about an MCS. If you're in a center where you don't have something beyond balloon pump, you cannot do an Impella, you cannot do an ECMO, this is the time to consider to call your main center. So here at Methodist, we're going to start something called the shock team. There will be someone on call to get calls from the peripheral hospital for cardiogenic shock patient. It's going to go live in January. So if you have a patient like this, you can always reach out to us. We can discuss the case and decide if we need to bring the patient over here to put them on some kind of mechanical support, or we can do something at your facility and then bring the patient over, or they can give you also guidance about how to manage these patients. Thank you. Erica, do we have time for questions? Or?
I do have a question.
Go ahead.
So for these patients who are on device, do you proactively checking their coagulation, like take PT-INR daily, and proactively treating it, or you just wait? And what's the normal hemoglobin that you would like to keep?
So your question is, what's the goal of anticoagulation? What PTT we target?
Yeah, coagulation and hemoglobin.
Yeah, so in terms of anticoagulation, it depends on your patient. If you have a patient with high risk of bleeding, sometimes we start with a flat rate heparin, for example, like 500 units, evaluate, see if the patient can tolerate it, then we can move to a lower PTT target, maybe 40 to 60, and if the patient can tolerate that, this is when you go to the full therapeutic dose, which is PTT 60 to 80. We still use the PTT here. If you're using other agents, like Ngemax, you can still use the PTT. There is something called the direct thrombin inhibitor also too that we also use to see if it correlates with the PTT. But I would say it depends on your patient. Again, someone who's bleeding, you're not going to start anticoagulation on. Once things start getting better, probably start them on some dose of heparin and move from there while we're watching for the hemoglobin and also watching for any signs of bleeding. Now, what hemoglobin target? It's a kind of discussion now. I mean, nobody knows the answer. Every study that's been done on the hemoglobin target always exclude patients who have ischemic heart disease. So 7 probably is a lower target for these patients. Usually in my patient, I try to keep them between 8 to 9. I think this is the sweet spot. Some places they go all the way up to 10. Some places they're comfortable with 7. I think the answer is between probably 8 to 10. So if you can keep them around 8, I think you're going to have enough oxygen delivery and enough hemoglobin. Any other questions? Yes, Sam?
Is there a shift from using a balloon pump versus an Impella now, like for short-term CP versus a balloon, or more advanced? Like, what are the advantages of doing CP versus?
Yeah, that's a good question. So Impellas are getting more popular. They are more available now. The cardiologists are more comfortable with them. Especially if you have someone with multi-vessel disease, sometimes they put the Impella in before they do the PCI or the intervention on them. Is there a shift? I would say yes. I mean, we're seeing more and more Impellas happening. And again, you have to think about what my patient needs. If I have someone with a left main disease, is a little bit hypotensive, is going to have a surgery in a couple of days, then probably a balloon pump should be enough. If I have someone who's an EF is 15%, they have a high lactate, then probably a balloon pump would not be enough. So probably we should consider put them in Impella early or put them on ECMO. So it all depends on the patient. But yes, I mean, Impellas are getting more popular, and you're going to see it more and more in your ICUs. Any other questions? All right, thank you.